Ashley has pain in the front of the right femur in an area corresponding to what I think is the femoral nerve. And there was no injury, there was no specific incident that started this. It just came on suddenly. About how long ago, Ashley?
A couple weeks.
Just a couple of weeks ago. And then after some days, you started to have pain on the same side, on the SI, and up the lumbar spine. So the structures that I'm thinking about here are definitely the femoral nerve where it crosses under the inguinal ligament. I'm thinking about the sacrum, and I'm thinking about the lower rib cage, and the structure that really ties all of those things together is the psoas. So we may be doing some psoas work today. Right now I'm just palpating, so this may be ticklish.
It's tender.
Tender, okay. So I've got your ASIS right here, and from that ASIS going down to the pubic tubercle right here, that's where the inguinal ligament is. It's not very long, and the femoral nerve is right here. It's right under my finger. That's it. Can you lift your leg just a little bit? Good. So holding it there, you can see the rectus femoris here and the tendon of the psoas here. Go ahead and let that down, and that femoral nerve crosses right over those two. That's it. Okay. Did that hurt or tickle?
That was a little tender.
Okay. Did that reproduce any pain down the front of the thigh?
No, but
Okay.
it was spicy.
Okay, spicy. So let's follow that femoral nerve down as it comes along the front of the femur and see if there's anywhere else that catches my attention in terms of textural change, change in mobility, maybe a sense of swelling and a little bit of stuck right here. Okay, very sore down the whole way. Okay, I'm using moderate pressure, not too much. I don't definitely, anytime I'm palpating along a nerve course, I don't want to do any deep work like grinding it against the structures underneath. That can injure the nerve, and we definitely don't want to do that. Okay, so it definitely feels tight and tense, but it doesn't feel real hot and inflamed, which is good. So I'm getting green lights here to do some gentle manual therapy. Ashley has some hypermobility, so we definitely want to be careful about stretching and mobilizing, and we want to be really moderate and judicious, cautious about that. Okay, so in terms of the course of the femoral nerve in the thigh, the two places it's most sticky are right here and right here. So let's start here. So what we have is the adductor and gracilis here. We have the sartorius coming here, and otherwise it's quadriceps. And so it feels like where the sartorius really starts to roll medially, that's where things are getting stuck a little bit. So let's get just some gentle mobility here in the layers. So what I'm doing with my fingers of my left hand is I'm pulling those outer muscles, the sartorius and the quadriceps, toward me, while I just really gently mobilize the femur into an internal rotation underneath that, okay? So we're getting some differential movement between the planes of tissue in the middle of the thigh here. Our goal here is just to start to impart some movement and get some mobility into this tissue. And I'm going distal to proximal because I don't want to miss anything. I don't want to mobilize it in the pelvic bowl and forget about it here. And potentially, if we mobilize it here first, there'll be a lot less work to do in the iliac fossa, the pelvic bowl up here, and that would be good. Good. I like how this feels here. This is moving a little better. And I'm starting to now sense like that restriction also here in the deep distal quad, right here. And this mobilization that I'm doing seems to be helping, so we're just going to keep doing it. Does that feel okay?
Mm-hmm.
Okay, good. into more movement elsewhere. And there's a lot of bodywork systems out there that are very protocol heavy. You know, for an entrapment in the quadriceps, you lay the patient on their side and you flex the knee and you externally rotate the hip and you do this and you do that with your hands, and that's fine, but it takes away from your ability to feel what's happening in this patient's body and kind of intuit what needs to happen, and it takes away your ability to use trial and error. And trial and error can be so incredibly useful, and it only takes a couple of minutes to determine whether or not the person's body is responding to what you're doing. You know, observe their breathing. Are they relaxing? Are you starting to feel these tissues mobilize under your hand like I am now? And if so, then just keep doing what you're doing. How are you doing, Ashley?
I'm doing
You
good.
good? Okay. Okay. So let's follow this up toward the psoas now. Okay, and here the tissues start to get a little bit more sensitive as you come up toward the hip joint itself. So it's nice to lighten up the pressure, not use the very tip of your finger, but more using the flat of the finger and broad contacts so that it doesn't feel too pinchy or too pokey. And right here is where we're really starting to get into some stuck territory. So let's continue with this rotational mobilization of your femur, okay? But what I want you to do is for you to roll your thigh like this and then relax. So you're going to internally rotate and relax. Yeah. And as you relax and externally rotate, I'm going to put some medial pressure on this superficial fascia here overlying the psoas, the rectus femoris, and the iliacus, and just start to release this, basically. If you need a break, let me know, okay? Okay, good. Keep going. Yep. Let's say 3 more good ones, okay? 1, 2, last one, and relax all the way. Good. So now I'm on the center of it. Feels like a trigger point in the psoas right here. And so gentle static pressure just for about a minute. Okay, does that feel all right? Good. I know you have been under a lot of stress lately, and we do, as humans, tend to put a lot of stress into this area of our body. So see if you can use your breath to kind of increase the pressure. Can you direct the breath all the way down into this deepest part of your pelvis here? Yeah, good one. Keep breathing like that. And as you do, I'm going to start using a little movement here. It feels to me like I'm able to really circumscribe the knot for you, and that's working better than the direct pressure was. That just let go really nicely. Did you feel anything shift in there?
Yeah.
What did that feel like for you?
Relief.
Felt like relief. Good. Yeah, that's moving way better. She is nice and relaxed and got her comfortably supported on the table here. Nice to have a prop under the top knee so that the hip stays in neutral. If the knee falls toward the table, the hip is going to be in a little bit of adduction, and it's going to be a little harder to feel. So in this position, I work a lot in this position because there's so many things you can access here. Starting from the top, you've got, well, the whole shoulder. We're not quite going there today, but for this, our purposes, we've got the lower rib cage, the diaphragm. If you're working on their right side, you got their liver and gallbladder. If you're working on their left side, you got their stomach and spleen. I have her quadratus lumborum here, all the layers of abdominal muscle here, and access to the iliacus and the iliac fossa here. All those things. And then the iliac crest, so many important attachments here from the internal oblique, the external oblique, the transverse abdominal, and the QL, all of those things. And particularly like that 2 inches or so from the very top of the crest going posterior, there's so much going on right there, and it's really nice to work that. So I'm just going to start there. I'm going to work this space. Okay. Can you roll ever so slightly this way without feeling like you're holding yourself? Are you pretty relaxed here? It might help to bend this knee just a little bit forward. Good. Okay. So looking at the structures, here is her PSIS. So this is S2, S1, and I can feel myself fall off the sacrum right here. Remembering that sacral base is oriented this way, and so L5 is really going to be oriented facing inferiorly as well, and there's L5. I'm on the spinous, the junction of the spinal laminar junction of L5 here. There's L4 and 3, and 3 is really the forwardmost part of the normal lumbar lordosis. So a lot of times L3 will be the one vertebra that is under the most strain, and it feels like that is the case here today. There's L2, L1, and that gets us to the thoracolumbar junction right here. Take a deep breath. You can really see her rib cage moving nicely, and as I'm palpating along those upper iliocostalis attachments, it feels a little tight but not too ropey, okay? So I'm not too concerned about the rib cage, always looking at the thoracolumbar junction, but really it does feel like L3 is where things are having the most trouble. And that was where, when I pressed before, it was a little too much. Is the pressure okay now, Ashley?
Mm-hmm.
Okay. So what I'm feeling here is L3 struggling a little bit, and I think what happened is that tight psoas has pulled it down on the right. So we're going to get a little elevation or a little separation between L3 and 4 transverse processes here on the right side. So let's get this leg straight and straight in line with you and just kind of let the weight of it hang. And I know I said before to bring your arm down, but let's bring the arm up. I want you to really kind of get some opening into this right side. Perfectly done. Good. Breathing in and out. Good. Well done. So I have a lot of contact on her leg right now. So it might look like I'm trying to pull her iliac crest with my one finger, but that would be ridiculous. So with my right elbow, I'm on the thigh, and I'm using all this my whole upper body to pull inferiorly on the right side of her pelvis, her right hemipelvis. And as you breathe in, Ashley, and those right ribs come up, we're going to get some nice separation on the right side. Good. We're going to do that again. So breathe out. I'm feeling like I want to use a little more of my hand here, and I can get my hand on her iliac crest. So a nice deep breath in. Perfectly done. Beautiful. That's it. Good. I think 2 more like that. Okay. Does that feel all right? Good. Breathing in. Breathing out. Good. Last one. It's much looser. Deep breath. Good. Paying a lot of attention to watching the breath, feeling the breath, and then relax. Good. So as I was mobilizing that and I felt it loosening up, I became aware of a restriction in the QL. It's right here. Right there. Is that tender?
Yeah.
Okay. Is that too much pressure?
No.
It's quite a pinch. So keep your breathing nice and soft. And as she breathes, I don't know how else to describe this. I'm sort of going to ask this muscle what it wants. And I know that sounds crazy, but I feel like that's one way to find out, is just engage it and listen. And the sense that and this is very intuitive, the sense that I'm getting is that the restriction is not in the muscle, but in the junction between the muscle and the superficial fascia, which is where I am right now, okay? So if we go through that, as she breathes out, I've got the muscle here, boom, between my fingers. And if I come off the muscle a little bit, I feel it kind of squeech under my fingers, and there it goes. And I would just want to be right where that muscle has its junction with the deepest part of the superficial fascia, right there. And let's get the mobilization right there. That's the spot. Probably pretty sensitive. Good. Great. Deep breath, yeah. So now as I come back and repeat that other mobilization where her ribs come up with her in-breath and I traction down on the ilium with the out-breath, I feel like that QL is much more cooperative now. And now the space that I'm concerned about is here. Right there, there's a trigger point. Boom. And I can't really describe how I felt that. It's just like if there was a tablecloth on a table and there was a plate at one end of the table and I was blindfolded and I pulled on the tablecloth, could I feel where that plate was? That's really the best way that I can describe it. With practice and attention, you can kind of learn how to sense where fascial restrictions are distally, even if you're not quite right on it. You can sort of sense the general area of it, and then you palpate there and you feel the roughness and the stuckness. And where we are right here, by the way, is the external oblique. So these are attachments of the external oblique as it kind of blends with the serratus anterior here on the lateral rib cage and the axillary line. And of course, this takes us back to the femoral nerve entrapment because the inguinal ligament is the other end of the external oblique abdominal muscle. That's good. Nice deep breaths. So we did a lot. We did femoral nerve mobilization in the thigh and the hip. We worked out trigger points in the psoas, iliacus, QL, external oblique. We mobilized the iliac crest in relation to L3, and hopefully we'll give our patient some good relief. My recommendation from here would be to follow some of my instructions that I have online for relaxing the pelvic floor and getting some pelvic floor relaxation into both sides, but particularly this right side to soften that. If there's a lot of stress in your life and you're putting it into that part of your body, that's kind of inevitable, but what you can do is learn how to counteract that and take some time every day to dissipate, discharge, relax, and give your body a chance to let go of what accumulated during the day. Does that sound good, Ashley? Okay, good. I'll send you some video. You're welcome. Any questions before I go? All set? Great. Thank you. Okay.
I feel so free. Thank you so much.
You're welcome.
My whole right side feels like it can breathe for the first time in like 3 weeks.
Great. Awesome.
Thank you.
You're welcome.
Yeah.
Thank you. Appreciate it.